Please, guys.
Hello, welcome all. Today again, coming back to the Road Academy. So today we'll take on the session 4. In this, I would like to discuss in brief what the this algorithm approach towards the calcium. So I would like to share this slide, which shows that once we find a calcium, then we have to prioritize that what type of calcium we are seeing and how we are going to approach it. So this is a slide that shows on intravascular ultrasound on IVUS. You can see it is a bright white echo, uh, which shows there is a bright structure, and behind this there is a dark structure. But we can see that in this only one quadrant is involved. So we can say it like a mild calcium. But when you see a 180-degree arc of this bright white micro deposits of calcium, and if it is around 180-degree, then it is moderate calcium. And if we see that it is present in more than 3 quadrant or 4 quadrant or more than 270-degree, then we should think that we are dealing with the severe calcium. And many times nodule that I discussed in the earlier slide also, the structure, bright white structure near the catheter, which has a dark acoustic shadowing on this is suggestive of a calcium nodule. So there are some scores that are based upon the imaging, and one of these is the OCT based score developed by Akiko Fujino et al. This shows, so this is the way how I remember that we should keep a rule of around 5. That means if arc is more than 50%, that is more than 180-degree, then it is important, then you will give 2 points. If the thickness is more than 0.5, then you give 1 point. And if the length is more than 5 millimeter, you give 1 point. And there is a scoring 0 to 4. And if the score is towards higher side, more than 3 or towards 4, then the chances of stent expansion are less. 68% as compared to the 90% if the score is less. So means if an OCT you find, and you have to keep in mind the rule of 50 or 5, more than 50% of the arc, more than 5 millimeter of length, or more than 0.5 millimeter of thickness. That means you are dealing with a significant calcium. And on IVUS, the image I just showed 2 slides back, that if the arc is more than 180 degree or 270-degree, that means you can give 2 points. If the calcium arc is more than 270-degree, then it is 3 points, that more than 3 quadrants. If the calcium length is more than 5 millimeter and thickness is more than 0.5 millimeter. So we can see the most important thing, the more the severe the calcium is, we are going towards the strategy that will need a debulking or high pressure OPNs or lithotripsy. So practically, now the things come that how simply I should approach this algorithm. So if you see a mild calcium, then we should treat it like a routine angioplasty. That means we can consider a balloon predilatation with non-compliant balloon at high pressures. So this is the thing that we all do. But when the things comes in category of moderate to severe calcium, so first and foremost thing, the most important thing that should come into mind is whether the lesion is crossable by the IVUS catheter or not. So try to put a IVUS catheter. If it is not going, that means you are dealing with the superficial calcium. Superficial calcium, I would again say that is near the catheter and more than 50% of the intimal medial side. So you should straight away go with the root ablation or sometimes orbital atherectomy. So for moderate to severe calcium, uncrossable catheter, no confusion, go with rotational atherectomy. Now, what about in moderate to severe calcium? If it is a moderate calcium and we are able to pass the catheter, then we should look for this 3 things: the arc of calcium, the calcium length, and calcium thickness. If you see these are on the higher side, then and the calcium is on the deeper side, that is in the lower 50% of the thickness of the intima and media, then we can go with the lithotripsy. But if it is on the superficial side, then we may consider rotablation. And if we see the arc is not more than 270, or you get only 2 points, that means it is a thinner calcium, length is less, then we can Of course, think about the very high pressure NC balloons that are available in India, like OPN balloon. And we can also, if you see a suboptimal result, then we can combine it with the lithotripsy. So many times after rotablation, we sometimes do lithotripsy, and it is called as rotatripsy. And once you get a good bed preparation, we can go with the this stenting, and after that we can see how the result is. So after discussing this, I would like to discuss the case again, how to start with the simple cases, then escalate the complex ones. So 66-year-old male, hypertensive, angina since 2 years, hemodynamically stable, ejection fraction normal, and this is how his angiogram look. So for beginners, I would say this is an ideal case, because on fluoroscopy, you can say there is a tram track appearance. We can see at this point when there is no dye. So at the cursor, we can recognize there is a blackish shadow on both sides. This is called as tram track appearance. The calcium is present on the both sides. And once we do intravascular imaging, we can see a bright white micro deposits that are calcium, and that is concentric. In center, it is the central catheter. And beyond this, you can see there are some rings of this acoustic shadowing. Sometimes it is suggestive of a thin calcium, but again, it is concentric, it is 360-degree. So we are going to deal with the rotational atherectomy, and this is a good case because the length is less than 3 centimeter, and it is non-angulated and non-tortuous. So dealing with this, so this is how you go with the burr 1.5, and after rotablation, the burr crosses, and we go with the non-compliant pressure, non-compliant balloon at high pressure, and after this, we can implant a DES, and end result is good. So this is how, and in next session, I would go with case by case, and we'll discuss how to prepare the rotablation, how to look for how to prepare the assembly, how to prepare the rotasolution. I'll go into the basic details of the rotablation machine, and after that, we'll also discuss about the RotaPro that is available, and it is a bit more better as compared to the already existing ones, and we are fortunate to have at our center. So we are routinely doing it, and I will let you know it in the next session. Thank you all.